When a child presents for transplantation, a complete evaluation is performed, and this includes a nutrition assessment. The nutrition assessment should be performed baseline prior to the start of the transplant conditioning regimen and should continue throughout the child's transplant course. And really, the transplant nutrition assessment is no different from an assessment for children with other disorders and includes the following. Of course, we want to review the nutrition and diet history, as well as physical assessment, arm anthropometry, and general anthropometry. We also want to review the child's growth and weight history, as well as biochemical indices and medications for any drug-nutrient interactions. Following the assessment, we then want to evaluate the goals of nutrition support for each of our patients. And some of the short-term goals of nutrition intervention include to identify and prevent or correct protein energy malnutrition and any metabolic abnormalities. We also want to try and preserve lean tissue as well as promote growth and development. And finally, because this is such a challenging procedure, we want to certainly try and maximize the child's quality of life. Once we've completed the nutrition assessment and established our goals, we then need to calculate out the child's nutrient requirements. And if we look first of all at energy needs, there's a variety of different formulas out there that can be used, and I've just listed a couple on the slide here, where we can utilize the basal metabolic rate for younger children and the basal energy expenditure, or BEE, for older or heavier children. Typically, baseline needs can be calculated using the basal rate times about 1.4 to as high as 1.6 for younger children, and stress needs may be as high as 1.6 to 1.8. Energy needs are typically increased in the first 30 to 50 days post-transplant to account for the physiological stress induced by the conditioning regimen, fever, sepsis, acute graft-versus-host disease, metabolic complications, and growth demands. Protein requirements are shown in this slide and are based on the child's age and weight. Actual weight is used, however, an adjusted weight can be used for obese children. Baseline protein needs are typically high to promote tissue repair following cytoreduction and to spare breakdown of lean body mass. And during active graft-versus-host disease or catabolic corticosteroid therapy, protein needs may even be further increased. Fat in the form of intravenous lipids typically comprises 15 to 30% of total energy intake. And while we really don't know what the optimum amount of lipid calories is for a transplant patient, we certainly want to provide enough fat to prevent essential fatty acid deficiency. Fluid requirements are highly individualized. However, general guidelines for fluid recommendations can be shown here. A daily evaluation of the child's weight with monitoring of intake and output are important methods to assess fluid balance. Fluid needs are increased during episodes of fever and with GI losses, and also with treatment of nephrotoxic medications, whereas fluid may be restricted during episodes of volume overload or hepatorenal failure. Specific vitamin recommendations for pediatric transplant patients are unknown, but for the oral route, an iron-free multivitamin mineral supplement with 100% of the DRI for age is recommended for all children for 1 year post-transplant, and even longer for children who remain on long-term immunosuppressive medication. We maintain all of our patients on iron-free supplements, as children have typically received multiple red blood cell transfusions either pre-transplant or during the transplant course, and are at increased risk for excessive iron stores in solid tissues, making iron supplementation contraindicated. Calcium and vitamin D supplementation is often necessary for children treated with corticosteroids, and recommendations are shown on this slide. Moving on to parenteral vitamins and minerals, We typically employ the standard pediatric parenteral vitamin and mineral preparations in accordance with recommendations provided by the Nutrition Advisory Group of the American Medical Association. We do include additional vitamin C to promote tissue recovery via collagen biosynthesis after cytoreduction. Additional vitamin C, however, is contraindicated if the child's serum ferritin level at baseline is greater than 1,000 to decrease oxidative damage from release of free iron, which happens during the conditioning phases. In the presence of hepatic dysfunction, copper and manganese, biliary excreted trace elements, should be removed from the parenteral nutrition solutions, as manganese toxicity has been reported during hyperbilirubinemia in the transplant population. Additional zinc supplementation above the standard replacement guidelines should also be recommended during periods of prolonged diarrhea, and supplementation guidelines are also shown on this slide. Electrolyte requirements vary as GI losses, impaired renal function, aggressive nutrient repletion, and medications influence needs. And it is very important to closely monitor the child's serum electrolyte levels and supplement accordingly. Well, refeeding the child post-transplant can be a slow process as the child's appetite and tolerance for food fluctuate widely. Oral intake tends to be minimal during the conditioning and neutropenic phases of transplant due to multiple GI complications, including mucositis, nausea, vomiting, and other regimen-related toxicities. And with engraftment and resolution of symptoms, oral intake generally begins to improve. An oral diet is indicated for a child with a functional GI tract, and it's important to individualize the child's diet by offering small and frequent servings of foods and fluids the child enjoys and encouraging parental involvement to enhance oral intake. Children with pre-existing delays in feeding development may benefit from occupational or speech therapy. And child life specialist intervention can also be helpful during the refeeding period. These individuals often have creative techniques in using medical play to help children learn to eat. Well, for the child with whom we employ an oral diet, we then need to look at what kind of diet we're going to place them on. And because food may serve as a potential infection source, most transplant centers utilize some type of an immunosuppressed diet or low microbial diet based on the theoretical concept of reducing the risk of contacting infections from pathogens found in food sources. High-risk foods identified as potential sources of organisms known to cause infection in immunosuppressed patients are restricted. At the Seattle Cancer Care Alliance, our autologous patients follow the diet for the first 3 months after transplant, while allogeneic patients follow the diet until they're completely off all immunosuppression. Dietary counseling and nutrition education on high-risk foods and safe food handling is necessary during immunosuppression. The protective benefits of a low microbial diet, however, have never really been established because of a lack of randomized controlled trials and certainly warrant further study. However, most transplant facilities do place restrictions of varying degrees. And I wanted to just show you the diet that we are providing to our patients, again, at the Seattle Cancer Care Alliance. The diet was developed by our department as well as the infectious disease department by culturing several hundred food items to evaluate the risk for potential infection. And as you can see, it's a well-cooked diet. We do allow fresh fruits and vegetables as long as they're washed well. We also encourage pasteurized dairy products. Well, while oral diets is the preferred method of support when the GI tract is intact and functional, enteral nutrition may be recommended for the child who is not able to sustain an adequate oral intake. We all know that enteral tube feedings help to maintain gut integrity and stimulate mucosal repair. And they serve as a vehicle for oral medications, are associated with fewer venous issues, and are more cost-effective.